So my name is Alan Kaplan. I'm a family physician from Richmond Hill, Ontario, just north of Toronto in Canada. And I chair something called the Family Physician Airways Group of Canada, which is a group of primary care doctors with an interest in respiratory medicine. I also chair the respiratory medicine section of the College of Family Physicians. And I was one of the authors on this new report called The Shifting Paradigm of COPD Management. Well, I've been very involved in the management of lung diseases, especially COPD, for the last 20 some odd years. And it's nice to be able to have a primary care perspective on issues like this. So I thought it was important to have not just the specialist component, but both the patient component and also primary care component. Well, COPD has always been a big issue. It's just, up until now, it's had a bit of a negative press, to use the word press. And mostly because it's a condition that has been looked at very nihilistic approach. The approach has been such that we can't really do very much about it. People are going to die from this, which is true. It happens very much because they were smokers, which unfortunately is partly true. And with all that in mind, it wasn't looked at as something we can do a whole lot about. But that's changed. With guidelines both in Canada and around the world, we now look at this focus of COPD as being both preventable and treatable. Preventable by making an early diagnosis, and as such, then hopefully trying to get people to give up the demon cigarette smoking, a terrible addiction, be able to do things to help them from having the disease progress. Treatable because we now have more and more medications to assist people's quality of life from symptoms, first of all, with breathlessness, with what we call long-acting bronchodilators. By keeping the lungs open, people can do more. And then looking at the future risk, looking at the risk of exacerbations and disease worsening over time by putting in anti-inflammatory preventative medicines and measures to therefore prevent the disease worsening over time and having the complications of it. Well, the report is emphasizing more on the second half. So up until now, we've mostly looked at COPD as a symptomatic condition, a condition that requires things to help people be able to breathe. Long-acting bronchodilators to help them be able to walk a little bit further, breathe, be able to sleep at night. But now we're looking at what can we do to prevent the worsening of the condition, the attacks that occur, and ultimately preventing early onset of death. So this is what we call future risk. So by using the appropriate medications, the appropriate anti-inflammatory medicines, the appropriate inoculations, by getting people to be adherent to the medicines regularly, we can keep people well for longer, with a better quality of life for longer, and obviously not die as early. Right now, the COPD is the number 4 cause of death. By the year 2030, it'll be the number 3 cause of death worldwide. So we have a lot of work to do in this condition, and that's the focus of this, to improve management of COPD, looking at both symptom control and future risk, and to be able to give healthcare professionals and physicians an approach to be able to individualize their therapy for each individual person in front of them. I mean, it's an ongoing work. COPD is developing more and more interest. First of all, as we're defining it better, as we're diagnosing it better and earlier, and now as we have more and more treatments. 20 years ago, there wasn't any treatment for it other than short-acting bronchodilators. It was a very frustrating condition to treat because you couldn't help people. But now we have medicines to treat the symptoms better. We have medicines to prevent future risk. There's so much more we can do. It's so much almost more rewarding to treat a condition, be able to do something to help your patients more. So that's the shift in the paradigm. There's so much more we can do for COPD patients. It's not just something that's a death sentence and put them back to bed until they're not there anymore. Absolutely, governments are sitting up and taking notice for a few reasons. Number one, it's a common condition. Number two, it's a very expensive condition. And as I've said, that for someone who gets hospitalized with COPD, they stay in hospital longer than just about any other condition. So that's a very expensive thing for government. So they sit up and take notice when costs are a lot. So if we can actually treat things better, treat things earlier, we can prevent those hospitalizations and complications and cost. So yes, there has been big changes in multiple governments. I'll speak to the UK and to Canada. In the UK, there's an entire now COPD pathway that exists in the UK that physicians are now forced to plug into in order to get part of their compensation. There's standards. In Canada, in a couple different provinces, Saskatchewan has now a chronic disease pathway, as does British Columbia, a few different provinces, where physicians are given a bit of an incentive to manage their COPD patients per a particular model. In Ontario, where I work, is now developing chronic disease models also for COPD management, and we've just created a COPD flow sheet to help physicians manage their COPD patients in Ontario. So the cardiovascular, what we've learned from the cardiovascular community are a few things. Number one, if we educate people aggressively about what they should be afraid of, they learn. So you know that if you have chest pain going down your left arm associated with shortness of breath, you should go to the hospital to make sure you're not having a heart attack, because you could die. Well, if you get admitted to the hospital with a COPD exacerbation, your risk of in-hospital mortality is the same as that of an acute heart attack being admitted to hospital. That's pretty scary and not recognized. So we want people, first of all, to recognize COPD is an important condition. It's important to diagnose it early to prevent the complications. Well, if we treat hypertension early, we prevent stroke and heart attacks. So we want to diagnose early and prevent things. Smoking cessation is obviously huge. We want to, if you have a worsening, to treat it very aggressively so we don't end up in the hospital. The other lesson is that preventative treatments work. So in diabetes, we use various medicines to control the sugar. In heart disease, we use medicines to control the cholesterol. We use a baby aspirin to prevent the vessels from clotting. In COPD, we want to use medicines to prevent the worsenings and the attacks as well. And we have a variety of medicines that include vaccinations, some of the inhalers, and some of the new medications like the oral tablet called roflumilast or Daxus, which is specifically a medication to prevent exacerbations in COPD. An exciting new breakthrough. Well, more and more, first we learn the lessons, but more and more the different healthcare communities are working less in the silos they've been up till now. And guidelines are now starting to mention other conditions because the treatments in one condition will modify another condition. We learned, for instance, that the treatment of people with COPD with a cholesterol medicine called a statin will decrease mortality in patients with COPD. Not because particularly I don't think it's affecting the lungs, although it might, but more because it's preventing cardiovascular mortality, which is one of the causes of death in people with COPD. So by working together, we can actually improve the outcomes of people with COPD and what we call multimorbidity. They've got a lot of other things that matter with them. Treating those other problems makes the success for the patient to be better, the individual person. So we're now starting to work with cardiovascular societies to look at people with heart failure, for instance. Well, these people can't breathe. It's been blamed on their heart for years. But actually, if you go back, they're ex-smokers, and if someone goes ahead and does a spirometry, discover they're also short of breath because they have COPD as well. So yes, we're starting to work more. I think the major thing you see with people, with groups working together, are the guidelines start to include patients with other conditions and how you specifically would treat those people within the guideline of that condition you're treating. So patient-physician relationship is the crux of everything we do. And you have to be able to feel comfortable to speak to your physician and ask questions. Your physician has to be able to communicate back. We have to learn to use words that are going to be understood by our patients. And sometimes we tend to get into medical jargon, and that may just go right over the heads of people we're talking to. So we have to make sure we can communicate in a way that's understood. We have to make sure the message is understandable. Saying the word COPD exacerbation, it's a mouthful for anyone to say. That may not mean something to someone. So, saying, well, if you've got emphysema and you cough up green stuff, you're sick, come to the doctor, or eventually have an action plan. So we have to be able to communicate that. If patients don't feel comfortable to talk, then they're not going to bring up issues. So an example of that is, I'm short of breath, I'm wheezing, I'm coughing all the time, but I don't want to go to the doctor because he's just going to tell me to quit smoking. Therefore, I don't get my diagnosis made of COPD because I never complained about it. And believe it or not, we actually can't read minds. So if you don't tell us what's going on, we may observe things, but sometimes it's hard to tell a little bit more. So yeah, the most important thing is to be able to talk to your physician, and for your physician to be able to make sure that he can communicate instructions, he or she, back to you. Interesting question. the COPD treatment is becoming much more aggressive as we have more options. So up till now, we've been pretty good at treating symptoms, okay, by using long-acting bronchodilators. They're now becoming even longer and longer. They were 4 times a day, twice a day. Now there's once a day, and now there's combinations of these medicines which make it work even better through multiple pathways. That's very exciting. We have medicines targeted to prevent exacerbations, decrease inflammation. Inhaled steroids, and now roflumilast or Daxis is the newest one. That's very exciting. We have new vaccinations trying to prevent the infections in the first place. That's exciting. There's new medicines being looked at all the time in terms of newer stuff, newer anti-inflammatories, new mechanisms of bronchodilation. That's important and exciting. And the things we can do earlier on in a smoker to help maybe reverse some of the damage. That's very early stuff, very exciting. We're not quite there with that. So the most important step is going back one full step, and talking to my 20-year-old smoker and trying to get them to say, you know what, I know you feel fantastic now, and you all will feel fantastic now, but down the road you may not, and the only thing that's going to prevent that is you giving up that bad habit now. And come to us and let us help you with smoking cessation at this point now. Don't wait till you're symptomatic. By the time you wait to the fact that you can't breathe, and you come to me and say, I can't breathe anymore, you've lost likely half your lung function. It's not too late to do anything, but sure is a lot later than I'd like to be able to improve your quality of life and improve your outlook and your prognosis. So going back to the beginning is converse to what you're saying, but going back to the beginning and prevention, I think, to me is the most important thing.
Thank you very much.